you have touched each and every aspect of where we can give the use, where you can use the fibrinolytic agents. So any queries from audience?
I think we should go to the next topic. Thank you. Thank you so much. Ah. So the next speaker is Dr. Umesh Pandey. He is professor in the Department of Cardiology, IMS BHU. His topic is pregnancy with valvular heart disease, how to manage.
Just for a correction, I'm associate professor, ma'am.
Oh,
Still,
doesn't matter.
yeah. So, very good morning to all, respected chairperson and the learning audience, and my heartfelt thank you to Alok sir for inviting me to this prestigious conference and giving me this talk. So, this talk may appear little bit different from our routine cardiological topics, but this is also the responsibility of cardiologist only. And so far, how this has been very much, I think, overlooked by the our cardiologist community. So, I will be discussing how to manage a valvular heart disease in a pregnant woman. So, we know that cardiovascular disease complicates 1 to 3% of all pregnancies and is responsible for 10 to 15% of the maternal mortality. And the incidence of valvular heart disease or cardiovascular disease in pregnancies is increasing because of the better screening methodologies and better treating modalities available. More of the more women are reaching up to the childhood. Rheumatic heart disease is still the most common cause, and mitral stenosis is one of the most common cause of mortality. And presence of valvular heart disease in a pregnant woman presents challenges in their management. So we all know that there are disease affects the aortic wall, that is stenosis or regurgitation. So stenosis is significant when it is more than mild stenosis. There is moderate to severe stenosis, symptomatic or LVH is there. Uh, Pulmonary valve stenosis is very well tolerated until and unless there is RVH or prior arrhythmia is associated. Regurgitation is also very well tolerated until and unless there is a poor RV function. Tricuspid stenosis is a rare isolated entity, and regurgitation TR is very well tolerated until unless it is associated with poor RV function or abstinence anomaly. Most common and important mitral stenosis is a very high risk condition. If it is symptomatic, severe stenosis, there is a dilated left atrium, elevated pulmonary arterial systolic pressure, there is a complex subvalvular disease or arrhythmias are associated. Most of the resistant lesions are very well tolerated, and certain things to be excluded like Marfan syndrome, mitral valve prolapse with ventricular arrhythmias. So looking at the hemodynamic changes, we all know that during pregnancy there are major hemodynamic changes which occur, mostly increasing from the second to third trimester up to 20 to 40% increase in the cardiac output, plasma volume and heart rate, and there is a compensatory fall in the peripheral vascular resistance. And all these changes peak at the time of delivery, and so most of the problems during delivery are faced during the peripartum period. So all those women who are suffering from valvular heart disease, they are potential mothers and should be there should be a proper preconception counseling and evaluation. So all those women of childbearing age should be counseled properly with proper history taking and ECG and echo examination, and planning should be started when they are still in the like preconception stage. For mild to moderate disease, review and adjustment of medicine for follow-up of every 3 to 5 years. For severe valvular disease, before delivery, they should be counseled about the surgical or percutaneous management of their condition, and they should be jointly managed with the by a heart valve team, which consists of like cardiologist, neonatologist, obstetrician, and cardiac anesthesiologist. And important issues of anticoagulation should be addressed. There should be regular follow-up during pregnancy. There should be multidisciplinary approach during labor and delivery. Most of the cases, vaginal delivery should be preferred, and antibiotic prophylaxis should be considered where indicated. So proper risk stratification is important. This is the WHO classification, which classifies uh, pregnancy with heart disease in 4 categories, and depending upon this categorization, appropriate strategies to be followed. For WHO class 1, patients are at low risk and there is no increase in mortality and morbidity. Patient can be followed up with cardiologist to limit 1 or 2 visits during pregnancy. Similarly, for class 2 to 3, uh, follow-up should be more frequent, and WHO, which are the more sick patients, should be managed, counseled against the pregnancy or managed appropriately before conceiving. So these are the predictors of neonatal events in pregnancy of women with cardiovascular disease. That is, if the presentation NYHA class 3 or 4 or cyanosis, there is a left heart obstruction disease, there is low maternal oxygen saturation, multiple gestation, anticoagulation, cardiac medications before pregnancy, mechanical valve prosthesis, maternal cardiac event during pregnancy, and maternal decline in cardiac output during pregnancy. So what should be the mode of delivery? So type of delivery mainly depends upon the hemodynamic status. Multidisciplinary approach should be taken. These delivery must be best accomplished in tertiary care hospital, and with advanced valvular heart disease or systolic dysfunction should be closely monitored until the early postpartum where hemodynamic decomposition is most likely to occur. So vaginal delivery is the preferred mode of delivery in most women, even those with established CV disease. And until unless there is any contraindication, they should opt for the vaginal delivery. And those patients considered stable from the cardiological perspective should allow to spontaneously progress through the stages of labor. Advantages include less blood loss, absence of abdominal surgeries, and more rapid recovery and decreased thrombogenic risk. Epidural anesthesia allows for controlled descent of fetus to the pelvic floor. However, epidural catheter is contraindicated in patients on anticoagulation. Assisted second stage must be tried who cannot tolerate the longer second stage of the labor. Though the caesarean delivery eliminates the hemodynamic insults associated with the labor, it is associated with more significant blood loss and more abrupt hemodynamic changes. There is increased risk of venous thromboembolism infection and postpartum hemorrhages. General anesthesia is rarely required in the setting of caesarean section and mainly reserved for the hemodynamically unstable patients. So coming to the individual component, most common etiology in pregnancy patient of AS is bicuspid aortic valve, and they can tolerate pregnancy if they are mild diseases uh, during pregnancy, and overall mortality is less than 1%. However, with the increasing valvular stenosis, there is increased incidence of unfavorable outcome of the fetus. Heart failure occurs in 7 to 17% of the patient, and arrhythmias occur in 3 to 33 patients. There is no optical medical treatment for AS. Patient may respond to the restriction in activities as well as reload reduction with cautious use of diuretic if they are symptomatic. If unresponsive to medical therapy, then termination of pregnancy in the early stages of pregnancy, catheter-based valvuloplasty, and surgical valve replacement in later stages depending upon the clinical status and availability. And symptomatic patient should undergo surgery prior to pregnancy. Even asymptomatic patient with EF less than 50% or exercise-induced symptoms should be counseled for surgery before conception. Caesarean delivery is usually preferred in these patients. However, in non-severe AS, vaginal delivery is preferred with avoidance of epidural anesthesia, which may lead to marked decrease in peripheral vascular resistance. And bicuspid aortic valve is also associated with multiple aortopathy, so these things must be looked beforehand to avoid catastrophic complications like aortic dissection and rupture during the pregnancy. So mitral stenosis is still the most common cause. They are very poorly tolerated during pregnancy. Important thing to note that direct craniometry is the most reliable measurement of the mitral valve area during pregnancy. And hemodynamic condition during changing hemodynamic condition, determination of mitral valve area by continuity equation is likely to be provide a better estimation than the pressure half time. Functional significance is more dependent upon the pulmonary artery systolic pressure and the mean gradient across the valve. So heart failure occurs frequently in MS patient with valve area less than 1.5. Prematurity is 20 to 30%, IUGR 5%, stillbirth 1 to 3%. And these patients are classified as class 4, and percutaneous balloon mitral valvuloplasty are the preferred option in symptomatic patients refractory to medical therapy. So they should be counseled against pregnancy, and PTMC should be performed beforehand. Vaginal delivery can be safely performed, and in severe cases, cesarean section can be done. Resultant lesions are very well tolerated because of the fall in peripheral vascular resistance. However, if there is LV dysfunction or pulmonary congestion, they should be managed with diuretics and vasodilators. And treatment of severe valvular regeneration surgically is rarely indicated in pregnancy, with the exceptions of treatment of infective endocarditis due to its life-threatening nature. Vaginal delivery is the preferred mode of delivery in women with severe resistant valvular lesions. PR is also very much tolerated except for the when it is associated with abstinence and only it can lead to heartbeat failure and arrhythmias. PS usually well tolerated until associated with RV dysfunction. Balloon valvuloplasty is the safe option but rarely indicated during the pregnancy. Similarly, PR is also well tolerated if there is no RV dysfunction. Another important issue is the management of anticoagulation in these patients. So we should remember that the thrombotic events with warfarin are the least as compared to heparin or LMWH. But problem with an early pregnancy is of the embryo problem with the organogenesis. So during the first trimester, they should be switched with the ultra fraction heparin or LMWH after discussion with the patients. And if the dose of warfarin is less than 5, they can be continued throughout the whole pregnancy. For second and third trimester, up to 36, they can be safely continued. Beyond 36 weeks, they should be replaced with LMWH or UFH with targeted monitoring. Now, if the patients present on anticoagulation in the labor, we should check for the INR and stop vitamin K antagonist. And cesarean section should be considered with general anesthesia with the infusion of the FFP or PCC. If the patient is receiving LMWH or UFH, then we should stop this. For LMWH, if he can deliver in the next 24 hours, okay. Otherwise, consideration of protomenis or neuraxional anesthesia can be taken for cesarean section. Prostatic valve thrombosis is also a dreaded complication, and there are reports that slow thrombolysis can be successfully performed in this patient. Very slow ultra low dose thrombolysis can be done with these patients. Now coming to catheter based intervention, so invasive interventions may be needed if there is hemodynamic determination, and cardiac surgery during pregnancy is associated with high fetal loss. Catheter based interventions provide alternative therapy to surgery during pregnancy and discussion should be based with the experienced multidisciplinary cardio-obstetric valve team. So this is a component of the cardio-obstetric valve team, and it manages the patient not from the pregnancy but from the pre-conception stage. It consists of cardio-obstetrics, cardiology, maternal fetal medicine, valvular heart disease, advanced echocardiography, structural imaging, and multiple other persons are involved in this. So there is a risk of radiation is main concern for fetal safety in transcatheter interventions, and fluoroscopy and CT guided intervention should be optimized to achieve the clinical purpose and no more radiation exposure than necessary. Risk of fetus depends on the radiation dose and the gestational age with the highest radio sensitivity during the organogenesis week 2 to 8 and neuronal stem cell proliferation phase 8 to 14. If possible, the procedure should be performed after this period and consultation with the qualified medical physicist encouraged to estimate potential conceptus dosing. Radiation doses to be kept as low as possible, less than 50 milligram. Although use of shielding is thought to be preventable, but most of the radiation injury is because of the scattered radiation from the thorax, so it is not of that much beneficial. And for procedure outside the abdominal pelvic region, most of the conceptor dose is attributable to the internal scatter of the thorax of the mother. So in catheterization laboratory, collimation of windows, avoiding angulated views, optimal table height, decreasing the fluoroscopy frame rates, and utilizing fluoroscopy safe features instead of angiography can all reduce the extent of radiation to the patient and fetus. So these are some recommendations for intervention. For severe AS, intervention is recommended before pregnancy, and mitral stenosis, if the area is less than 1.5, surgical treatment is recommended before pregnancy. In patient with severe AR or MR, for asymptomatic severe AS, intervention should be done before pregnancy. PTMC, if the patient is severely symptomatic or systolic PSP more than 50 despite medical therapy. Valve surgery during pregnancy should only be considered when there is a maternal mortality risk and other treatment options have been failed. In very selected symptomatic pregnant women with severe AS not responding to medical therapy, non-surgical options such as balloon valvuloplasty or TAVI may be considered. So again, mitral valve resuscitation, there are many strategies, but they are usually not required because they are very well tolerated lesions. Similarly, pulmonary stenosis also we can go for BPV if the gradient is more than 36. But as the event rate is low with these conditions, so they are usually rarely indicated. So again, so these techniques are associated with this of ionizing radiation. I think we have discussed all this. So now what we are doing? So recently the BHU is taking participation in this ICMR funded project which is run by the AIMS New Delhi and Madras Medical College, and it is the development, implementation, and evaluation of protocolized cardio-obstetric care in improving maternal cardiac obstetric and fetal outcome of pregnant women with heart disease in India, that is NPAC India registry. So almost 56 prestigious institutes of our nation is involved, and BHU is one of the site which I am leading as the principal investigator. And the target is to reduction of the maternal mortality ratio. So primary objective is to develop, implement, and evaluate an evidence-based cardio-obstetric care protocol in improving outcomes of pregnant women with heart diseases in India. And secondary objective of develop and validate a risk stratification tool for these patients in India and test the applicability of existing risk score for Indian population, that is WHO score, Carpregg score, Zahara score, or Devi score. So it is basically a cohort model to develop the risk stratification tools, Delphi method for stakeholders engagement for development of concessions on intervention, that is protocolized cardio-obstetric care, PCO care, cluster randomized control trial to evaluate the effectiveness of the intervention model, and quantitative and qualitative process evaluation of implementation of interventions and immediate outcomes. So to conclude, valvular heart disease in pregnancy is an increasing common cause of adverse complication for both mother and baby, with medical and surgical advances allowing for many patients with valvular heart disease to survive to childbearing age. And we recommend an integrated risk stratification schemes for pregnant patients with valvular heart disease with WHO classification, an algorithm approach to both preconception counseling and anticoagulation strategy as outlined here, as well as early referral to the cardiologist with expertise in the management of cardiac disease and pregnancy for these complex patients. So our aim is to prepare a cardio-obstetric care at BHU where the cardiology meets motherhood with precision, compassion, and hope. Thank you for your patience hearing.
Thank you, Dr. Umesh. The topic was very big. You covered almost every aspect of this topic.
Thank you.
Any question?
Recently, prosthetic mitral valve. The patient was on acetron, uh, less than 5 milligrams, but they wanted guarantee that this was early pregnancy. I had recommended switching over to low molecular weight heparin. Can we guarantee that there is safety to and that there will be
Sir,
no?
actually,
Because I said no, I cannot guarantee. You should go to low molecular weight heparin.
yes, sir. Sir, as we have discussed that the for prevention of thrombotic event, warfarin has the lowest rate. Even UFH and MWH has a higher thrombotic event as compared to warfarin. Problem with warfarin is the embryopathy which is associated. Though they recommend that less than 5 you can continue, but there is no absolute guarantee that it will not occur. That is the issue, sir.
Once you're able to avoid during first trimester, it's the safest drug, less than 5 milligram dose.
Yes, thank you.